It's a 5-year-old child with trivial trauma. As you can see, both the eyes, there's a like almost popped out picture. And she had just fell from the cot, and this is how she got, and she also had a large scalp hematoma, and we suspected a bleeding disorder, and the saving grace was her pupillary reactions were normal, although there was a lot of exposure keratopathy. And factor 13 deficiency was found, and cryoprecipitate was transferred, blood transfusion was given. The anesthesia was high risk because of the bleeding disorder. Lateral canthotomy was done. The extreme chemosis for that conjunctival incision was done, and this subconjunctival fluid was drained out using a periosteal elevator and a muzzle hook. And after this reduction of the subconjunctival fluid, that's the extreme chemosis, the globe was reposited inside using a periosteal elevator. Desmarks can also be used according to literature. And a temporary suture tarsorrhaphy was done on the lateral side. Same was repeated on the medial side as well. So you can see the same thing is done on the medial side. Center I have not taken because cornea will get injured. On third day the sutures gave away. We did the same procedure again 2-3 times, and 1 month later this is how she was. 3 months later, from here to this position with the factor 13 and all, she developed a little corneal haze, but she got 6/18 vision with a good near visual acuity as well. So this was the first case involving both the eyes with trivial trauma. And this is the second case with a road traffic accident where the globe had luxated outside. A similar procedure was done. Here also lateral canthotomy was done, and what I want to tell is this lateral canthotomy will be left like that. We will not suture it in the primary setting. And again, here this patient was PL negative and pupil was completely dilated. The aim of the surgery here is to preserve the globe. Definitely the vision is not there, but to preserve the globe, the extraocular muscles had got disinserted in this case. And same way, the lateral and medial tarsorrhaphy, leaving the central cornea unharmed was done, and this is the immediate 1 week post-op, and this is 3 months post-op, and you can see here extraocular muscle disinsertion and all, and corneal thing. Surprisingly, this patient did not develop anterior segment ischemia in spite of the extraocular muscle detachment, and he is due for squint surgery as well as the repair of the lateral canthus and the lateral tarsal strip procedure. And this is the third case of spontaneous globe subluxation in a craniosynostosis baby, the Krausen syndrome. And one eye, again here, the chemosis is the thing which prevents the eyeball to go back. A similar procedure was done. And here also it was 2 to 3 times that we did the same procedure. And she is due for a skin graft, which I am telling in the next case how we manage. And this is a case for bulgur injury and with a large amount of laceration on the lateral aspect and also extraocular muscle tear and all. So even in this case, it was managed similarly, and again there was wound gape, and we did the same procedures again and could salvage the eyeball. This is again another craniosynostosis case. I'm sorry, the pre-op picture is missing. So here what I have done is all the 4 lids I have put skin grafts to additionally add tissue because the orbit is shallow. There is no way to give volume, so skin grafts were added on all 4 lids and lateral tarsorrhaphy was done, and this is how he is. So the globe can be either partial or complete luxation, and etiology is usually traumatic and sometimes spontaneous also, and usually any object entering in the medial orbital wall is the cause, and sometimes optic nerve avulsion is also possible. So one of the things many people resort to whenever there's globe luxation is to enucleate, so that is something which has to be avoided. Although vision cannot be salvaged, it's a very big mental trauma for the patient to lose his eye as well. So we have to do all to prevent enucleation. We can do the temporary tarsorrhaphies and all and preserve the globe, and later for the cosmetic thing we can again do squint surgery and lid surgeries and give a good cosmetic outcome. Thank you so much. And these are the references. Thank you.
Was there any associated orbital wall fracture or any meshes used for?
No, ma'am. These patients did not have orbital wall fracture. So the basic thing in globe luxation they tell is the severe contracture of the peripheral orbicularis oculi. Once the eyeball comes out, the orbicularis contracts and then it prevents the eyeball to go back. So these patients did not have fractures. We did have one bear attack in one lady where it had gouged out the eye in one, and the other severe fractures were there. But there the eyeball was dangling, so there was no support, and I enucleated. That is the one case where I did enucleation. But these cases did not have fractures.
It's a large series. I really congratulate you.
Thank you.
You
So
are very
much.
nicely done, Apun.